haven't attended one of these sessions before, my name is Laura Bryden and I'm one of the AHP NATH ambassadors. So working alongside Desi, who will say hello in just a second, to kind of help put on these training events. We're very grateful today to Ahmed, who's joined us from QMC, who's an advanced spinal practitioner there. So he's a physiotherapist by background, was previously working in primary care, and has moved over to work in this specialist role in secondary care. So great to have him here today. Obviously he understands things from both sides now. So he's put together a really informative, great presentation for us. I'll just hand over to Desi to say hello.
Hello, so I work as a first contact practitioner physio in South Notts, but I'm also a clinical lead for mental health OTs in primary care.
So just a couple of housekeeping bits before we start. We'll monitor the chat box. So if there's any questions you'd like to ask, please just pop them in there. The session is being recorded and we're aware a couple of you have opted out of being recorded, which is absolutely fine. So if we could just suggest you leave your cameras turned off. And if you do have a question, if you just pop it into the chat box and then we can read it out for you anonymously. So yeah, the session's just being recorded so that it can be used as a resource by people at another time. So if that is everything, then I'll hand over to Ahmed to get started. Thank you.
Hi Laura, hi Desi. Yeah, it's good to see you again. I used to work with them previously. Right, so as Laura said, I am one of the spinal practitioners. Let me share my screen. And I'm a physiotherapist by background. I've been working in the musculoskeletal field for over than 13 years. I worked in community musculoskeletal and interface MSK. I completed a master's degree in advanced musculoskeletal management. I worked in primary care for a few years. And I've been working the spinal unit in QMC for over a year now. Can you see my screen, guys?
You're on, you're not on presentation mode yet. There you go. Perfect.
Perfect.
There you go. So basically, I work in the neurospinal assessment unit. It is a same-day emergency care in QMC. It's predominantly for surgical intervention for emergency spinal pathologies. Right. So it's a consultant-led service, and it's run by on-call spinal practitioners and spinal fellows. So basically, spinal fellows are responsible for any like fracture problems, and spinal practitioners are responsible for like Cauda Equina, infections, all the degen problems. We have access to whatever we need, whether scans, same day MRIs, X-ray, CT scans. What we can do if we identified any emergency spinal problem, we can list for emergency surgery with the on-call consultant, list for on-call MDT. If it is not the same day, we need to discuss in our MDT, which run every morning. We can list for injection, prescribe, optimize medications if needed. We operate basically from Monday to Saturday, 8 to 8. We accept our last patient at 6 p.m. So that's basically giving the overview about the neurospinal assessment unit. So the plan of the session is mainly we talk about more service access, because we always get that feedback from everyone that we don't know how to access the services, and a lot of people, they don't know actually about the neurospinal assessment unit for emergency spinal problems. We talk about different spinal pathologies, how to identify it and how to manage it, because basically identifying spinal pathologies, specifically serious one, early is very crucial, because it affects the patient management and their function levels significantly. And also there is a lot of legality in it. So time is crucial in identifying spinal pathologies. Talk about some case studies and eventually ended up with some questions and answers. Service access. So we accept patients basically from everywhere. Primary care staff, GPs, advanced nurse practitioners, FCPs, paramedics, pain services, MSK interface services, different specialties, rheumatology, except we open for any services. Basically, our catchment area is Nottinghamshire area, East Midlands, but more specifically Nottinghamshire for lumbar problems. we can accept from Lincolnshire and different places for cervical and thoracic problems, and definitely for emergency, we can accept from anywhere in East Midlands. So the way you can access the neurospinal assessment unit is just to phone the QMC number and just put the extension number. So this will redirect you to the neurospinal assessment unit. So I put two numbers. The spinal fellows usually call them if it is fracture. So you call the QMC number and the extension 86217 if it is anything else apart from fractures. Okay. So we'll listen to your story, we'll discuss it with you. If accepted, we'll book in. If not, we'll give you an advice how to manage it. So that's basically the way you can access the service. It's very straightforward, simple. Just call us. As I said previously, we operate from 8 to 8. We accept last patient at 6 o'clock, Monday to Saturday. So if anything out of these hours, unfortunately, you will need to transfer the patient to ED, to A&E basically, if you suspected serious spinal pathology. Is that clear? Has anyone tried to call us before? Just open to the room to give me a feedback. How did you find it, or how did it work? I can see Tim. Yeah, you can jump in the call, Tim. Yeah.
Yeah, I mean, a couple of times, probably before this service was set up as well once, and then once since the service was set up, just going through switchboard, and I found it very helpful. So thank you very much.
All right, perfect. Oh, thank you. Thank you for this. I appreciate it. Yeah. Anyone else?
I've always found it reassurance, especially when you're in that like 2-week mark where you don't know what way it will go. It's always good to have a specialist to either reassure or say, no, that's something we need to do.
Has anyone tried? Thank you for that, Daisy. Has anyone tried it before and didn't find it helpful, difficult to access it, or any bad experience? Just to get an idea about it.
Ahmed.
Classic, isn't it? Yeah. So let's talk about common serious spinal pathology. So I just want to open it to the room. Can you either the text box or the chat box, or just unmute yourself and talk? What do you think, guys, is the common serious spinal pathology? Here I mean that pathology that need emergency input. Can you throw it to me? Yeah.
Cauda Equina syndrome.
Absolutely, the classic one. Yeah. So basically the common ones. Fractures, absolutely. So fractures is always a quite tricky one, because there's sometimes you're unstable fractures, sometimes stable fractures. So, but fractures definitely is one of the common serious pathologies. So Cauda Equina, yeah, go on.
In the chat, we've got cord compression from other causes.
Absolutely. I can't see the chat box, unfortunately. Is there anything I can do that I can see it, or is...
We'll read it out to you.
Perfect, thank you. Yeah. So absolutely, yeah, compression of spinal cord for different reasons. That's one of the serious spinal pathologies.
Infections?
Absolutely, yeah. That's a big one, and it's always underestimated, and it's difficult to diagnose it. Because usually the spine's infection, because the spine structures are quite deep, so you don't get the classic septic symptoms. You don't get the swelling, the redness. Sometimes you don't get the systematic symptoms for infection. You don't get fever sometimes, so it's quite difficult sometimes to identify it. So absolutely, it's one of the big serious spinal pathologies. Yeah.
Tumor or growth?
Yes, definitely. So metastasis to tumor. So we have different classification for it. So sometimes metastasis is just an urgent, not an emergency, and sometimes it's emergency. It depends if it's compressing the cord or not. So absolutely, yeah, tumors is one of the serious pathologies. So let's go on. So Cauda Equina syndrome, the big one, acute foot drop. This is classified sometimes as emergent and urgent, and it is very controversial topic. Yep. Metastatic spinal cord compression, so as tumors has been mentioned, and cervical orthotic myelopathy has been mentioned, that compression of the spinal cord for whatever reason, infection, unstable fractures. Usually I don't expect this would be seen in primary care, because usually that's secondary to accidents, trauma, most of the time. And lastly, compression fractures. I put that under the serious spinal pathology because I know this is a very, very common thing you see in primary care. and they can be very difficult to manage. Not difficult because it's difficult, because the patient can be in significant pain, and you just don't know where to go with it. So we put it here. It's unlikely to be serious, but sometimes it can be serious, and we discuss the reasons for it. So basically, these are the common serious spinal pathology. According to the NICE guidelines, the conditions that are classified as an emergency and same day input is needed is Cauda Equina syndrome, metastatic spinal cord compression, infection, unstable fractures. But as we know with practice, sometimes myelopathy can be emergency, acute foot drop can be emergency, but according to the NICE guidelines, these are the emergency things that you will need to act immediately on it. All right. So let's move on. So foot drop. Yeah. So I will start with this one because, as I said, it's always difficult to manage, and every services has their own pathways and guidelines. There's no clear agreed pathways for it in the country, unfortunately. So that's just a bit of brainstorming. What are the common conditions that can cause foot drop? Foot drop can be caused by different things. So can we open it to the room? Just throw it to me, guys. What do you think?
Perineal nerve injury. Oh.
Sorry, go on.
Prolapse disc at L5S1.
Absolutely, that's the big one. Yeah, that's the very common one. The second most common is a common peroneal nerve injury. So I would just list them firstly, all of them. They would talk about everyone how they present. So these are the most common causes for drop foot. So yeah, nerve root compression, L5, L4 sometimes, and S1, exactly. The common peroneal nerve injury, that could be because of compression or injury. Peripheral neuropathy, central nervous system like stroke, but this would be quite obvious because it would be upper and lower limb. MS, if it's undiagnosed and it is the first attack, sometimes it presents as a drop foot, classic drop foot symptom, but it's actually MS. And the ALS, but that will be more progressive. It won't be acute, but patient can present with drop foot because of it. Muscular dystrophy, yeah, so that's a big one, but because usually it's undiagnosed and patient will present with bilateral drop foot. We see that very commonly and transferred to spinals, but actually muscular dystrophy. So usually that happens in middle-aged people, and it will be undiagnosed muscular dystrophy. And the most common type is myotonic dystrophy. It will be bilateral drop foot, and will be painless. So if you've seen any patient in your clinic with bilateral drop foot painless, just always put in your radar muscular dystrophy and polymyositis. That's like an inflammation in the muscles. That will be acute and will be bilateral. So just to go up again, so the spinal one, because of nerve root compression, usually it will present as a radiculopathy, back and leg pain, following dermatomal pattern. So we do like the basic ones, so just to identify back, leg pain, the pattern of it, SLR, slump, just the classic basic one to identify it. The common peroneal nerve, it will be the way it presents, it won't be painful, it will be more paresthesia, okay, following L5, L4 pattern, like the spinal pattern, but it will be below knee only, no back pain, no long leg pain, it's more paresthesia and weakness. The peripheral neuropathy, it like be like Charcot-Marie-Tooth, it will be bilateral, it will be a build-up, gradual, a lot of comorbidities, so just a holistical input, so that would be more bilateral, and as I discussed for the other types. So it's very important to identify before you act what is the cause of the foot drop, okay? So as now we talk more about the first one, the spinal nerve root compression, okay? So now we identify managing it. So in your clinic, you have a patient come in with foot drop. So you need to decide what you need to do. So basically, what most of the people do, just send them to A&E. Okay, that's the most common practice. So I just want to open it to the room. What do you usually do, guys, when you see in your clinic in primary care patient to present with you acute foot drop is more spinal presentation? What do you do?
Where I am in Newark, we have pretty quick access to MRI. So I would typically get a lumbar MRI. I'm never sure whether that's the right thing to do or not.
It's always good to scan it. Yeah, absolutely.
So I've never come across this clinically, but what I would want to do is, I did experience it. I suffered from it myself and had an operation in 1988, so I'm quite cued into it. But so I'd probably get in touch with the spinal team.
Okay, perfect. Absolutely, yeah, right. Anyone else?
So I actually had 2 episodes of it. One, I called you guys and the time frame was out, so it was one of those kind of wait, watch, and wait. Another one ended up being from an infective cellulitis in the calf. So actually, that was the cause. So to go through infectious diseases, being not that spinal would be the right team.
Okay, perfect. Anyone else? If you don't want to talk, just put it in the chat box and we'll, yeah. Generally, there are 3 ways we can manage foot drop. In more specifically, 2 ways, conservatively and surgical. So as I discussed previously, with the foot drop, acute foot drop management, we don't have a clear pathway in the country. Also, the NICE guideline is more talking about radiculopathy, right? And I'm responsible now in our center and in the Center of Spinal Studies and Surgery, the QMC, to generate a clear pathway. So we looked at the evidence thoroughly, and the up-to-date systematic reviews are basically consist of retrospective studies. So there is no high quality like randomized controlled trials. So we don't have a strong evidence supporting whatever the decision we do in the foot drop, and every services do it differently. But what we do based on the available evidence, clinical experience, and with reviewing our services, because we get a foot drop every now and again. So we have a data for hundreds of patients. So when we looked at it and comparing to the evidence, we found that for surgical indicator, if you have a patient with foot drop, when would you consider surgery? When would you consider surgical consideration to call the spinal team for surgical consideration? So first 2 points are working together. So the onset of symptoms and pain. So why they work together? Because when it onset of symptoms, mainly indication for acute inflammation. And if there is inflammation, that means there will be pain. And when we talk here about pain, we're talking about foot pain, not long radicular pain. So it's predominantly dorsal aspect of the foot. We're talking about significant pain, because if it is painful and the onset within 3 to 4 weeks, that gives us an indication there is acute compression of the nerve and the nerve is inflamed. And to decompress the nerve during that period, you will get the optimal outcome from the surgery, all right? So in that case, the surgical outcomes will be significantly, there will be, according to the evidence, statistic difference, and the benefits will outweigh the risk. So onset of pain is crucial, ideally 2 weeks, but we can stretch it up to 4 weeks if it is significantly painful. So these are the 2 things you look at, when and if it is painful or not. If it is not painful, even if it is acute, no need for surgical consideration, all right? Because in that case, the risk profile for surgery outweigh the benefit. So these are the first thing you look at. Number 3 is age. These information I put it here based on the evidence. But when we looked at the systematic review, they put age that usually after 60 years old is the time that you can consider surgery. Post 60, there will be no statistically significant difference between surgical intervention and conservative management. But when we look more, it's more about comorbidities, not actually age. Because if you have like someone in the 30s, diabetic type 1, uncontrolled, HbA1c hundreds, and they have acute foot drop, here the risk profile of the surgery will outweigh the benefits. So basically, we put it here age, but it's actually more about comorbidities. Because if there's a high comorbidities, previous blood clots, blood thinners, heart failures, uncontrolled diabetes, so the risk profile of the surgery will outweigh the benefits. So surgical indicator will be reduced at that time. Then also muscle power. So here when we talk about muscle power, when I classify according to the Oxford muscle grade. So there is a debate on which one is the foot drop. Okay, there are a lot of evidence suggesting that grade 3 on Oxford muscle scale is a drop foot. But actually, when you think about grade 3 that they have full dorsiflexion, but without resistance. So it is not technically foot drop. But other papers suggesting the foot drop because the more the patient walk, the more they'll get muscle fatigue and it will develop foot drop later. So according to the classification, we classified our service from grade 2, basically. So grade 2 is full dorsiflexion, but without gravity, so with gravity elimination. So when you decompress nerve, you gain 1 grade. So if it's an example 2, when decompressing the nerve, you gain more grades, so you move to 3, okay? So if it is 0, there is no movement at all, even there is no muscle contraction. So what we expect from decompressing the nerve is to gain 1 more grade. So it's 1. So actually 1 is still drop foot. So patient won't gain any functional advantage from having the surgery. So in that case, the risk profile will outweigh the benefits. And lastly, definitely patient preferences. So I will get to that point later after discussing the different treatment options. So basically, surgical indicators, very, very systematic approach, onset of the symptoms, painful. So these are the first 2 things. If it is not painful, it's not within 4 weeks, no need for surgical consideration. So the other options, so conservative options. So as I said previously, the evidence when they compared surgical with conservative, but these are mainly were retrospective studies, there were no significant difference in the outcomes, unless the indicator I mentioned previously. However, even with these indicators, the conservative management can be equally, you can achieve the same results with the surgical management. So if you want to take the conservative approach, as Laura mentioned, you have to scan them. You need to know the reason of the drop foot, because drop foot, that means there's a significant neurological deficit. It could be presented as a spinal presentation, but you cannot just act conservatively without imaging them, because it could be metastasis in the spine and there's a collapse in the vertebrae that compressing the nerve. You need to know. It could be MS. It could be, you need to scan them, and it has to be urgent within 2 weeks. So when you put in the referral, it has to be classified as an urgent. Number 2, just pain optimization, neuropathic non-steroids, anti-inflammatories. Neuropathic is quite debatable because basically the NICE guideline is not recommending it, but sometimes in practice with patients, you have to give them something to control it. You have to refer to physiotherapy and orthotics just to avoid any risk of falls. The other option, it could be considered injection, but before you consider injection, you have to scan them. As I said, we need to know the cause of it. Injection is a nerve root block, basically. So what I understand from primary care, you can access that by referring to the pain team and refer to orthotics as well. So injection is not always a preferable option. So it's the most preferable according to the evidence to start with either surgical or conservative. Is that clear? I haven't clarified that. All right, so let's put it in practice as a case study. Okay, this study I actually saw here. It is a 76 years old female. I was on call on that day and I got a call from the GP reported these symptoms. 2 weeks history of lower back pain after turning over in bed. 1 week history of left radicular leg pain L4, L5. Left ankle dorsiflexion. So this is mainly a subjective history. No CS symptoms, no upper limb symptoms. Past medical history, type 2 diabetes controlled, hypertension controlled, nothing significant. On examinations, there's a clear drop foot. So based on this information, if you had it in your clinic, what should you do? So it's 1 week history. What's the most important thing you want to know with the 1 week history? Does anyone want to jump on this?
Is this where you'd make a decision based on whether or not she was in pain?
Exactly. So if it is pain in the foot, not in the leg. So if they can present with radicular leg pain. So predominantly here we need to know if the foot is painful or not. So basically this lady, she had a painful drop foot. So it's 1 week, grade 2 out of 5 and painful foot. So GP phoned us, so he accepted the referral and brought her in without imaging, okay, because she hit the criteria for possible surgical consideration. So this is her MRI. So what we're looking here, can you see my mouse? So L543, so that's between L3, L4. On the right side here, can you see that gray? That's a disc, acute disc, compressing the descending L4 nerve root. Okay, So this is predominantly the left side, the left leg. So it looks the right side, but because on the scanner she was lying to the left foot. So she has acute drop foot. What I did when I saw her, we discussed with her the treatment options. We discussed the risk profile of the surgery. We discussed the conservative approach, and she opted for the conservative approach. So we requested outpatient MRI, urgent one, referred her to physio, gave her neuropathic, orthotics. Then I followed up here, I believe, a couple of weeks ago, just 100% resolved. So that's here what we want to talk about patient preferences. When you saw him, you need to discuss with them how it would work with surgery, what are the indicator, and also the conservative, sometimes it works. But you have to clearly document that you offered them possible referral to the surgical team, and they opted for the conservative, because from primary care, you need to make sure you document that. Is that clear? Right. That's about drop foot. Does anyone have any questions about it? Right, let's move on. So the other one is the metastatic spinal cord compression. It's not a common one, but identifying it and acting on it in a timely manner is a key. Because any delay with this, the consequences are quite significant. Okay, so as we know, it's a serious condition that occurs when the cancer metastases to the spine, causing compression of the spinal cord, the cervical and thoracic area. If that happened in the lumbar spine, basically the patient would go to Cauda Equina syndrome. Okay, so we call it Cauda Equina syndrome if it is in the lumbar spine. Cervical, thoracic, it would be metastatic spinal cord compression, which is more common in the thoracic area. So what are the common cancers that can cause it? Can anyone just give me an idea? What do you think the most common type of cancer that can cause metastatic spinal cord compression?
Breast cancer. Somebody's popped in the box.
Breast cancer, yes.
Lung, prostate,
cancer. Absolutely, yes.
myeloma,
yeah, absolutely. So here what I will show. So I will show you the type of cancers, and the percentage here is reflecting as a percentage of the whole cases of the metastatic spinal cord compression. So lung cancer is 20 to 30% of the metastatic spinal cord compression in general. Breast cancer and prostate, as you said, these are the big three, right? So lymphoma is 5 to 10%. It's no specific where is it, but it can cause it. A kidney cancer and myeloma, and usually myeloma, it is the undiagnosed myelomas that it can cause the metastatic spinal cord compression. So it's unmanageable. So these are the type of cancer. So basically, if you see in your clinic anyone who's a history of lung, breast, prostate, and presented with sinus symptoms of possible metastatic spinal cord compression, you need to act immediately. So the clinical presentation. So the most common thing is pain, and this will be the obvious symptoms. So it's acute pain, severely localized, predominantly around the thoracic area, because this is the most common area. You will patient will really struggle to lie down, because when they try to lie down, that you put more axial compression on the vertebrae, so it's compressing more of the spinal cord. They can't lie down, and sometimes we struggle to bring them in the MRI scanner because they can't lie down. So it is significantly pain. So here we're talking about significant levels of pain, and it is acute. Neurological, because it's compressing the spinal cord, expecting a neurological deficit. More obviously, it depends on the level, but as I said, it's more in the thoracic. So you're expecting more in the lower limb, and you're expecting like a band-like sensory loss distribution around the torso. These are this is the golden nuggets, so the sensory loss around the torso and pain, okay? So autonomic dysfunction, bladder and bowel, this happens usually later on, okay? So it won't be the acute presentation. Reflexes, you're expecting here hyperreflex in the lower limb and post-Babinski, because the spinal cord will be compromised and they will be imbalanced. So if you have seen in your clinic any patient with a history of breast, prostate, lung cancer presented to you is acute, severe pain, really severe, it's significant levels of pain. They wobbly with their walking, you have neurological symptoms. What you need to do is just call us, please, right? no MRIs, just call us straight away if you have seen this presentation in your clinic. I don't have a case study for it because it's just straightforward. It's clinical history and clinical presentation, and just warn us that's what you need to do when you see this presentation. Does anyone has any questions about it? Anyone saw it in their clinic to share any experience in primary care? Yeah.
I've seen people with spinal metastases, but not that's progressed to cord compression.
Okay, so in that case, what would you need to do? So first thing, if they already has cancer, which is diagnosed, you need to get in touch with the oncology team. All right, that's the first thing that we do. You need to do. You don't need to phone the spine if they are neurologically intact. Okay, so it is metastasized. There is a metastasis, but neurologically intact. There's no signs of metastatic spinal cord compression. The first act you need to call oncology. All right, the registrar or the on-call team for the oncology, and the oncology will get in touch with us later on. But if you suspect neurological deficit acutely with acute pain, so that's a different story. Don't wait for the oncology, straight away to spinals. That makes sense. So to the big one, yeah, the Cauda Equina syndrome, as we know, is 20 nerve roots originate from the conus medullaris. That's usually T12 to L1. Cauda Equina syndrome occurs due to compression. So it is straightforward compression. So the compression that can be caused by big disc, that can be caused by fracture, unstable fracture, collapsed vertebrae, metastasis, infection. So how the infection can cause Cauda Equina, because with the infection, there'll be abscess. So the abscess can go to the epidural, compress the Cauda Equina nerves. So you can go to Cauda Equina syndrome secondary to infection. So it's just compression, but the cause of the compression, it varies. But the most common one, as we know, is the disc, acute big disc. So we have a classification for the CS. So based on that classification, it will be the urgency of the surgery and where we are. So the first one is the suspected. So it is actually, could be a compression of the Cauda Equina, but it's not Cauda Equina syndrome. So in that case, we suspected CS. So the most common presentation for it will be back pain and leg pain. That could be unilateral or bilateral, okay? So basically with bilateral leg pain, you always suspect that this patient can develop CS. So we're talking here about bilateral radicular leg pain, not like a stenotic leg pain. Okay, is that clear? Right. The second symptoms is perineal changes in the sensation. So genital areas or back passage area, any sensory changes, they feel like the patient might tell you, I feel weird, I feel numb, I can't feel it. So here you have to suspect CS straight away. So altered bladder function. So that's an important point. So why the bladder is always related to the CS? Because the sacral nerves, the S2 to S4, is a parasympathetic nerves for the bladder. And the parasympathetic nerves is responsible for bladder contraction to initiate micturition. So if the parasympathetic nerves is compromised, so the patient will struggle to initiate micturition. So you're going towards retention, okay? So it's not like stress incontinence or just incontinence. We're going towards retention. The bladder is not contracting to empty the bladder, to initiate micturition. So when we talk about CS-related bladder symptoms, we're talking more about loss of desire to void, is struggle to initiate micturition. They have to push more. They don't feel fully emptied. Post-micturiation dripping, so it's more towards retention. You can have full incontinence, but that's very later on when everything is just gone, okay? So that's really important to identify about the bladder symptoms. It's more towards retention. because of the S2, S4. If they're going more towards telling you increased urgency, I just want to empty my bladder all the time, dribbling incontinence without any signs of poor stream or delayed maturation, that could be more bladders, just more urology problems or woman health, or could be upper motor neuron. So it's more in this higher up in the spinal cord, because the sympathetic nerves that supply the bladder is more higher up. So these are responsible more to getting more urgency, more overactive bladder. So CS is more towards retention. Is that clear? Okay. So the second classification is there is CS, there is Cauda Equina compression, but it is incomplete. All right. So urinary difficulties of neurological origin. So here's neurogenic origin. So the loss of desire to void is straining to empty the bladder, loss of urinary sensation, they can't feel it. So here we're going towards retention. The patient CS incomplete, that they need to decompress them same day, because they might develop to retention. So that's the Cauda Equina. So basically, Cauda Equina syndrome, we only classify as Cauda Equina syndrome when the patient went to retention. The patient didn't have retention, it's not Cauda Equina syndrome. It is more stenosis. Okay, so it's painless urinary retention, and here overflow incontinence. So here everything is destroyed, the bladder muscles destroyed, so they can, in that stage, they can go to overflow incontinence. Overflow incontinence is very unlikely during the early stages. This is not Cauda Equina. And the last one, Cauda Equina complete. So it's complete loss of the Cauda Equina function. These patients, we don't list them for surgery. We don't do anything for them, because here the risk will outweigh the benefits. With the CS retention, we try to act as soon as we can, but unfortunately at this stage, mainly there will be permanent damage. So in primary care, the ones we need to pick is the CS suspected. It's the most important one to pick. Okay, so let's talk about more diagnostic accuracy. So here, this is a brilliant research conducted in 2019 to look at the sensitivity and the specificity of the signs and symptoms of the Cauda Equina syndrome. So let's to clarify quickly sensitivity and specificity, because I know it's quite confusing all the time. So specificity to rule out. So what I mean by ruling out, so if it is a negative test, if it is a specific negative test, that means it is very effective in ruling out, not in ruling in. So just say in shoulder, easy one. So rotator cuff impingement. When you do all the rotator cuff tests, if they're all negative, no pain, here these tests are very specific in ruling out impingement. So if they are all negative, it is unlikely to have a rotator cuff impingement. If they are positive, it doesn't mean you have rotator cuff impingement, so they are not sensitive. Have I clarified that? Is that okay, guys? So look at the sensitivity. So here we're looking at ruling in, okay? So the most sensitive thing is leg pain. That's the reason we always look for leg pain. If there is acute bilateral leg pain, these patients, you need to do something for them. We'll talk what we'll do, but bilateral leg pain is a big flag for possible developing Cauda Equina syndrome. And the second most sensitive thing is saddle anesthesia, numbness or just altered sensation around the genital areas or back passage area. These are the most common signs or symptoms. Actually, urinary incontinence is less sensitive than leg pain or saddle anesthesia. Reduced anal tone, so bowel incontinence is very unreliable thing, because usually when you don't, the Cauda Equina nerves not controlling the bowel in any way, it's more the anal tone. Okay, so to go to bowel incontinence because reduced anal tone, this is a very late change. This usually happens with the complete Cauda Equina loss of function, so it's unlikely to see it in the clinic. So these are the most sensitive things. Regarding specificity, so if it is negative, it can rule out. It, according to the research, bowel incontinence is the most specific thing to rule out. But as I said, it's very not practical. It's unlikely to reach that level in primary care. So you're looking more for saddle anesthesia. If patient doesn't have any numbness in the genital or back passage area, it is unlikely to be Cauda Equina syndrome. And if the patient has numbness in the genital or back passage area with leg pain, it is very likely this would develop to be CS. So there's another research expecting 10% positive findings of CS and MRI with patients with cellular anesthesia. Okay, so these are the diagnostic accuracy of these signs and symptoms. So is anyone aware about the GRIFT guidelines in primary care?
Can we just go back for a question in the chat?
Yes, please.
Oh, sorry, let me just roll up. So if a patient with chronic back pain and prostate issues is now unable to pass urine, how do we distinguish between Cauda Equina and a urological cause for retention? Do we send to urology or to spinal?
So here we need that's always a tricky thing, all right? So if they presented with just retention symptoms and they are well known to have enlarged prostate or whatever the problem, the prostate, but without any worsening back pain, without any radicular leg pain, it's more likely urology. But here we need to talk more about timelines, which I will answer it the more I go. To clearly answer that question, I would talk more about the time frames and how it presents. So for the question,
Sorry.
yes. So for the go on.
Sexual function is always a tricky one. What are your thoughts on that?
So sexual function here. So what is it? This sexual dysfunction. So for men, mainly the most one we're looking at from CS, it is unable to achieve erection, unable to sustain it, and unable to achieve ejaculation. Okay. For women is less of sensation, so not able to achieve orgasm, can feel things as normal for her. So these are the sexual dysfunctions. These symptoms are very vague. If it is isolated symptoms, it's not Cauda Equina. So here we're talking about a combination of symptoms, right? So let's get back to our accuracy here. So that's the reason we're talking about sensitivity. So if it's a sexual dysfunction, as it is, it means nothing. It's not CS, as you know. But if it is associated, for example, case scenario, with new worsening back pain and radicular leg pain, and they're telling you the sexual dysfunction is altered because of numbness around the genital areas, here it is. So here's more CS. So clinical context and full history is the key. Did that answer your question? Do you want to follow up on anything?
Ahmed, I was previously told that if you did a Cauda Equina screen and documented it in your notes, but didn't document about sexual dysfunction at a later date, it could be, obviously, if your notes were scrutinised, that's quite a common reason why people are given compensation money. Is that something that you've come across, that people don't document sexual dysfunction clearly?
So, look, so there were always loopholes. You have to document it, unfortunately. Because if it went wrong for any reason, you didn't document it, it would be a loophole. So you have, you're actually right, Because Cauda Equina, that's the most common condition that people get compensating money. It's the highest condition that people can get compensation.
So even if you ask about kind of your bladder and your bowel, your sensation, and they're negative, you still need to ask about sexual function, even though, like you've said, it wouldn't be an isolated, that could still be a loophole.
Absolutely. And if they mentioned, yes, the second question, you need to, for how long, timelines, right? So in that case, usually the patient will tell you, all right, it's been like this for a few months, for a few years. So it won't be like an acute thing, not a new symptoms. However, if it is a new symptoms, please call us. If it is within 2 weeks, if you're in primary care, you need to call us. I will talk more about when to call us later on when I talk about the GRIFT guidelines.
We've just got a case on this. So a GP friend in her practice, there was a 25-year-old man with erectile dysfunction as the only symptom. It was missed by repeated GP visits, and it was Cauda Equina, and was suing, or he's suing.
So that can happen, but it's very just erectile dysfunction as it is for Cauda Equina syndrome is unlikely to be the only isolated symptoms. even if you looked at a safety netting card, we're looking at a combination of at least two symptoms. So erectile dysfunction. So here is a questioning more. Is it erectile dysfunction? Is it just erectile dysfunction, or is it erectile dysfunction because a numbness around the genital areas? So questioning here is very important. So is it just dysfunction, the erectile not able to achieve erection, or there is sensory changes around the area? So digging and the clear questioning is the key. Is that clear?
Yeah, really, really helpful.
Yeah, right. So here's the GRIFT guidelines. So it's mainly for primary care stuff. Okay. So patient has recent, what we mean here, 2 weeks or less, any onset of CS symptoms, even if the erectile dysfunction as it is, you need to refer to emergency unit. You need to call us. Okay. So even a single symptoms of the Cauda Equina symptoms, saddle, bladder, bowel, even if it's not specific, you just need to call us. All right. The other type of it, if it is sudden onset of bilateral radicular leg pain or unilateral radicular leg pain, the reason they highlighted the radicular leg pain because it is the most sensitive thing for a positive Cauda Equina. It's always the beginning of a Cauda Equina is the leg pain, but it is associated, isolated leg pain, whatever the timelines, bilateral leg pain, isolated bilateral leg pain, you don't need to call us. You need to scan them. So if you can do that through primary care as an urgent scan, but legally, it would be better to refer to the interphase MSK. Just to make that clear, patient presented with acute bilateral radicular leg pain, you need to refer them to the interphase MSK as an urgent referral, or you can request an urgent MRI, but you need to send an advice and guidance to the MSK service about that. So this is to cover you legally. So for acute bilateral radicular leg pain. The second point here is onset of CS symptoms, but more than 2 weeks. Okay, you don't need to refer to the emergency services if it is more than 2 weeks. Is that clear? But here is the question. The problem is, for example, because this GRIP guideline is not that helpful because sometimes you get patient 3 weeks history started with bilateral leg pain, then perineal or perianal numbness, bladder just poor stream. That's 3 weeks. Okay, so in that case, it's not emergency. However, within the last week, it's just start to find that it is very difficult to empty the bladder. They need to push. So here it's difficult. So if it is, has it got any worse within 2 weeks? So your clinical judgment here is a key. You will need to call us as well. If that makes sense, right? So this is basically the guidelines. So the key here is timing. When is it? Is it within 2 weeks? If it is more than 2 weeks. The reason they developed that because Cauda Equina compression that causes Cauda Equina syndrome, if that is more than 2 weeks, symptoms more than 2 weeks, it's unlikely to be Cauda Equina compression because the nerves won't survive more than 2 weeks. That's the reason they put that framework. So let's see some case studies to put in practice, okay? So this is 54 years old female, 1 week history of lower back pain, described as a heaviness across the lumbar spine, no radicular leg pain, reporting bladder symptoms, 4-day history of increased frequency, urgency, associated with intermittent dribbling and poor stream. No bowel, no saddle anesthesia, no upper limb, systematically okay. And she came to the unit, examination was normal, bladder scan, post void is 301. So actually she's in retention. Okay, so basically we consider retention from 200 and above. Okay, so what should we do in that case? What should you do if you're in the primary care, you have seen a patient, 54 years old, 1 week history of lower back pain, bladder symptoms? What should you do? Anyone want to? So
Call you.
Yeah.
Absolutely. So it is 4 days. So that's within the 2 weeks frame, and it is lower back pain. So you hear suspected CS, okay? So actually we scan here, and here's the spot. Absolutely fine. No CS, specious canal, no Cauda Equina, and it is UTI. Okay. So the previous question was just isolated erectile dysfunction, the question we get it previously, or for the prostate patient, you know that they're prostate, but they went to acute retention. Even if it is acute retention, but there is a worsening back pain, just call us. Don't call urology. I know that's common to happen, but from CS protocol, it is acute bladder symptoms, but associated with back pain, worsening back pain, or any signs of mechanical compression, just call us. Okay. So second case, I have seen this lady. It's 46 years old female. She has 1 year history of lower back pain, chronic back pain, but got worse a week before we saw her after a long drive. For the last 3 days, she noticed reduction of sensation in the perianal, vaginal, and buttock area, roughly 50% reduction. These symptoms has been getting worse gradually for the last 3 days. She has no bladder, no bowel, no leg symptoms, no sexual problem at all. On examination, no weakness, reflexes normal, reduced sensation S2, S4, normal DRE, normal bladder scan. She has no retention. So what should you do here? So here what we're looking for, time frame, number 1, 1 week history of worsening lower back pain, 3 days history of reduced sensation in the saddle area. As we discussed previously, saddle anesthesia is a very sensitive symptom, okay? If you noticed, if you've seen that, always suspect CS. So we scan here, and here is it. So it's a big L5S1 disc, fully compressing all the Cauda Equina symptoms, and she had the decompression same day within 5 hours. So here, there's no leg pain, no bladder symptoms, but it's worsening back pain and saddle numbness. So think about Cauda Equina straight away. So within 2 weeks, clear symptoms, you need to act on it. Is that clear? Number 3, 70 years old male. We see it all the time in our clinics. Long-term back and bilateral leg pain. Getting worse with walking, standing, getting better with sitting, bending forward. Has bladder symptoms, increased frequency, and post-micturition dribbling for a year. No saddle anesthesia, no bowel dysfunction. Past medical history, just hypertension, high cholesterol, asthma, BMI high. Examination is reassuring. Post-void 9 ml, so absolutely everything is okay. Here is his scan. He has a significant L3, L4 stenosis, and the radiologist reporting Cauda Equina compression. Okay, but he has no acute Cauda Equina symptoms, although he's reporting 1 year history of bladder symptoms, but that's mainly down to the prostate. Okay. So there is a difference between Cauda Equina compression and Cauda Equina syndrome. So this is lumbar stenosis. Okay, we classify that as an elective, not emergency, not Cauda Equina syndrome. So you see that a lot in primary care. This is not CES. So there's a difference between compression and CS. Is that clear? So golden nuggets for Cauda Equina. It is very common age 30 to 49. Because it usually happens with acute big disc, and usually elderly people, they have a lot of narrowing in the disc space, osteophytes, everything is rigid, so it's unlikely to happen. Right, go on, Dizzy.
So it's just a question in the chat. What is the critical time period to have Cauda Equina surgery before permanent damage sets in? From a couple of slides back.
So basically, which one? This one. So if the patient went to retention, we do it in the same day, right? If they're not in retention, we make sure it's maximum done by next day morning. So it's within 24 hours, basically. Yeah. That's the reason if you have any suspected symptoms, you have to call us and we have to answer your phone and bring the patient within 4 hours. So these are the time frames to see if we need same day scan. And if in their retention, we have to decompress them the same day. If they're not in retention, we can do it next morning, right? So golden nuggets, as I said, it is very common age 30 to 49. It is very unlikely at elderly people. It is more common in females. bilateral leg pain is the key, because usually Cauda Equina is a big central disc, and with a central disc, it usually compresses the descending nerve root. It is very common at L4-5 level, L5, S1. So that would be the L5 nerve or the S1. Right, go on, Tim.
So I've got, yeah. Sorry about that. I've got quite a specific question about compression, which I think you probably answered. It could wait till the very end. If you want to carry on, I just wanted to make sure I could ask it.
It's all right. No, you can ask it now. It's all right.
Okay. So specifically about a young person who went to Leicester Casualty last week for various reasons, with severe back pain and some reporting of decreased erections and urinary symptoms, particularly dribbling afterwards. And anyway, he'd been suspected as having CES. MRI excluded it. He's only 31 years old, so MRI excluded it, but did show that he had impingement via centrally prolapsing disc of the S1 nerve in the lateral recess area. So I did some reading around about that, and that's kind of a cause of spinal stenosis. So he's got a lot of symptoms still, massive pain on walking, claudication pain, very limited, only a young chap, fit otherwise, still reporting these issues with not having strong erections. And I'm just wondering how it's not fitting in with your spinal emergency, but I'm wondering this kind of cord compression, sorry, it might be out of breath for your talk, but how urgently would the spinal team deal with that, or how urgently would they see it?
So if it is on the scan is lateral recess stenosis, the S1, so that would be classified as an elective for radicular leg pain.
Right.
So we would classify the bladder symptoms and the erectile dysfunction is not spinal caused.
Right. It wouldn't be caused by the disc in that area.
No. It won't be, yeah.
Okay.
And that if further investigation would be needed higher up the spine, if there's any upper motor neuron or there's any other cause for it. But that's a good thing with the Cauda Equina syndrome. If it is not compressed on the scan, it is not spinal, not the lumbar area.
Right.
Yeah,
and those other symptoms wouldn't be caused by that disc? No,
it won't be caused. The only symptoms will happen is left leg pain will be left S1, if it is the lateral recess at L5 S1.
Yeah.
So we can see them, but for radicular leg pain, not for the bladder. Yeah.
Okay, thank you.
No worries. Yeah. So as I said, age is key. Bilateral leg pain, reduced ankle reflex. That's one of the most objective findings. It's actually more effective than the DRA test. Okay. Sudden anesthesia as well. Always consider UTI and benign prostate hyperplasia. So with old men with prostate symptoms, it always get very tricky when you think about Cauda Equina. So in that case, think holistically and time frames. If it is long term, more than 2 weeks, bladder symptoms, however, how bad is it? But if it is more than 2 weeks and it is just isolated prostate type of symptoms, it is not Cauda Equina, in that case, urology. But if it is worsening symptoms, the last 2 weeks, associated with back, leg pain, always think about CS. And as I highlighted previously, CS is very unlikely with elderly people because they don't have that healthy disc that can cause the significant compression. Okay, I know I'm running out of time, so if you want to stop me at any time, just tell me, please. Let's move on to another big topic, which is really underestimated in primary care in the NHS generally. There's a lot of growing research now on how to identify the cervical myelopathy, and we're running a big research in our unit is just to have a clear diagnostic criteria for cervical myelopathy. We collected data from 300 patients. It is a very important topic now. It is a hot topic. So usually the myelopathy it's like the Cauda Equina, but more in the neck. So there is stenosis in the spine. So it's usually spinal stenosis. Could be caused by spondylosis, disc herniation, hypertrophy, ligamental flavus. So it is spinal stenosis. But cervical stenosis is very common in everyone above 70. It could be acquired or congenital. It's like narrow canal, but it's not myelopathy. Myelopathy is a clinical diagnosis based on symptoms, right? Unfortunately, there is no single sign of symptoms. There's a massive spectrum in it. That's the reason it gets really tricky to diagnose it. It could be sometimes insidious, like acute, sudden, or progressive stepwise progression. So the spectrum of it is significant, right? But the most common sign is there is a neurological deficit with it, okay? So let's just try to make specific, right? So here, that's very broad according to the evidence base. But I'll just make it very specific for cervical myelopathy. What you're looking more is hand symptoms, numbness in the hands, more in the tip of the finger, reduced hand dexterity, atrophy in the muscles, but that could be in the later phase. But the first thing you're looking at is hand symptoms. The hand is the key. You can get radicular arm pain, but that usually, if there's a big disc, can cause foraminal stenosis. But with the true myelopathy, patient would tell you it's more the hand, and it is bilateral. They can have one side worse than the other, but it is bilateral most of the time. Later on, gait. They would tell you I'm quite imbalanced, quite clumsy while I'm walking. So, and other symptoms is the bladder. As I said to you, the sympathetic nerves for the bladder is higher up in the spinal cord, higher up, not like the parasympathetic for the lumbar spine. So the sympathetic will always telling you increased urgency and dribbling. So that these are the most common signs. So hand symptoms, numbness, lack of dexterity and coordination, imbalance, and bladder symptoms. Clinical examination. We love the myelopathy because you will get hard neurological finding. You can have evidence in your clinic and you can be confident diagnosing it. So gait, tandem gait, Romberg's, they're more likely will be wobbly, but that might be later on, not during the very beginning of it. But sometimes it can happen with young patients with big acute disc. The cord can get significantly stressed easily, acutely. So gait is the first thing you look at. Hand function, as I said, loss of dexterity, fine movements, and atrophy in the muscles, and upper motor neuron testing. So the good thing with the myelopathy, as I said, you can have hard evidence in your clinic. So the Hoffman test, just quickly, you flick the middle finger, you stabilize it in the DIP joint, then flick it down like this, then you expect the thumb and the index finger to move like this, okay? So that's bilaterally. The inverted supinator, you just hit with your hammer around the head of the radius, and you expect that the hand to move slight supination with flexions of the finger like this. And Babinski, as we know, and Cronus in the lower limb. So the upper motor neuron testing here are very specific but not sensitive. So what I mean by that, so if you have negative upper motor neuron testing, they're very strong in ruling out cervical myelopathy. Okay, so if you have normal upper motor neuron testing, that reduces the chances that it is myelopathy. Here you need to think about something else. If they are positive, they're not sensitive in confirming the diagnosis. So they are really strong in ruling out. So if you have hand symptoms, clumsiness, imbalance while walking, with positive upper motor neuron testing, it's very strong. You have strong evidence that it is myelopathy, right? So that's the cluster of findings to identify myelopathy, which is very, very sensitive. 94 to 99%, it's 3 of them or 4 are positive. So imbalance, positive Hoffman's, positive inverted supinated, but significant above 45. So 3 out of these symptoms, it is more likely myelopathy. Am I running out of time? So now we talked about how to identify it from subjective history and from clinical examination. We need to identify how you're classifying it. So we used NJA, okay. I want to get up just a second, get the MJA so you can see it with each other. Let me change so here's it. So that's a modified Japanese, something like this, like modified Japanese Orthopedic Association questionnaire. It's a very reliable questionnaire. According to the evidence, you have to give it to the patient to fill it. But in practice, we found that this is very, very unreliable, and you will get unreliable score from that. So it's covering 4 parts: upper extremities function, lower extremities, and sensation of the hand and the bladder function, basically. So what we found in practice, please don't give it to the patient. Just you can identify it. For example, the first one, So he was talking about able to do buttons, but slight difficulties. Here was great difficulty. Just ask the patient to do it in front of you. If you find them likely doing like this, it's very clumsy, so here you're moving to great. If they did it, but slowly, put it as a slightly. Who's walking, the second point, just let them walk in your clinic and see how they walk. If they're able to walk without walking the stick, here we go. So the only thing you need to ask about is stairs. So you go from 4 to 5. If they can't walk without walking the stick, just make sure, is it truly because neurological clumsiness or is because of arthritis in the knee or the ankle in the knee? So use your clinical judgment here because there's hundreds of reasons that can cause it. So try to be specific and use the clinical context. Here for the sensation in the hand, just do your examination. Don't just ask them, and based on what they will say or what the examination is findings, just score it. Okay. And with the bladder, be careful here with the other symptoms like stress incontinence or prostate or anything. So here we're looking for a new symptoms. Okay. So that's regarding the MJOA. So here the scoring, we have 3 scoring, mild, moderate, severe. So the lesser the number, the severe it is. For anyone with moderate to severe myelopathy, we have to offer them surgical consideration, right? So that's a very important thing. Any moderate to severe, you just need to offer them a surgery, okay? So what I mean offer them surgery, just refer them to us for surgical consideration. Let me get it down here. Don't want to be out of time. So can you see my screen? So that's the classification. So what should you do? So first thing, once you classify the patient, if anything is severe, you just call us, please, right? Don't just wait or do scans or anything. If you have a clear evidence, you have the symptoms, the hands, the imbalance, you have the positive upper motor neuron testing, you have hard evidence, they're very clumsy in your clinic, you score them in a severe, just call us, please. When it moves to moderate, like 12 to 14, here it comes very vague, right? So here you need to identify the progression of the symptoms, if it is stable or not. So it means stable, so it's stable for a month of a period, so it's no changes within a month. In that case, you need to request an urgent MRI, outpatient MRI, and wait for the results. If the scan came back with stenosis, in that case, you either refer as an urgent, elective, or call us if there's any deterioration, or if there is cord signal changes. Okay, so the myelopathy, it is a clinical diagnosis, but there has to be compression of the cord. If the cord is not compressed, it is not myelopathy. Okay, so you have to have both. And if it is mild, just request an outpatient urgent MRI and refer to us electively. Is that clear? Because it's very vague most of the time. Anyone has any questions regarding this?
There's probably more logistics, but you probably get it. So in terms of especially South Nottinghamshire, we can't do a cervical MRI in primary care. We're trying to get FCPs on it. We can't refer to secondary care MSK because anything that sounds spinal, they state that they're not a spinal service. Do you have any advice on these mild cases?
So is it because of Connect? We had a discussions with Connect, because we discussed that with them a lot because they have problems with insurance and things that they cannot accept the referrer. And we're trying to work it out with them now that we would see them in the unit. Yeah, if you
even if it's mild, that's where GPs, FCPs could refer
if it is mild, here it is very tricky because if it is mild, in a way, it is stable and mild, you should refer it to Connect. Okay. Would they accept it if it is a mild?
I think it depends how the FCP or GP writes it to say this is what it is with safety netting X, Y, Z, and the patient's aware if it deteriorates, then they must go back to primary care or A&E. I think it's more getting imaging because I know I had a case where they just said, well, you need to do it, but we're trying, but at the minute we can't.
Yeah, I got that. So any moderate or severe will be more than happy to accept it. But however, I highlighted, sometimes in the moderate one, when it is stable for a month, So make sure when you phone us, just to highlight the difficulty that you can't scan it, because what we would tell you most of the time, just get a scan outpatient. So just to clarify it and just to highlight that Connect can accept it, because we're aware about Connect problem, because they spoke with us about it. Yeah, right. So just a quick case study. All right. So 60 years old male, 4 months history, bilateral hand numbness, hands clumsy, the hand clumsy, 3 months history, bilateral leg and feet numbness, imbalanced, bladder symptoms, clear myelopathy symptoms, positive upper motor neuron, tandem gait, Hoffman's supinator, hyperreflexia, and ataxic gait. If you have that in your clinic, what are the most important thing you want to identify now? So you clearly identified that this is myelopathy. What you should do. What do you want to know that will lead you to the next action?
Yes, any recent changes?
Absolutely. So any recent progression in the symptoms. So the first line is 1 month, the second line 3 months. Okay. So that's the first thing. Number 2, you need to identify the severity. So the MJOA. Okay. How bad is it? Is it mild? Is it moderate? Is it severe? So this gentleman, I've seen him. So significant deterioration during a month period. He works in construction, but he lost his job because of the imbalance and clumsiness. He's not safe in the construction site because he keep falling and imbalance. And MJA here is 13. So based on this information, can you see in the scan here, there is a clear compression. This cord changes that whitening here, so the cord is compressed. So in that case, we actually admitted him and he had ACDF in the second day. So the on-call surgeon did it in the second day. So in summary, with cervical myelopathy, 2 things you need to identify. Any recent deterioration and the severity of it. MJOA, please don't give it to the patient. Just you fill it with your observation and your clinical examination to get a reliable outcomes, and use a very pragmatic approach. If it is severe, just refer straight away to the emergency service. If it is moderate and stable, if you can get MRI through outpatient, get an urgent one, then review with the MRI. Even if it's stable, refer urgently to the elective pathway. Any deterioration, it is a moderate MJA, just refer to the emergency services. Is it mild? Try to scan them. There is an evidence that there is spinal cord stenosis, spinal cord compression. Refer to the elective for us to monitor it. Is that clear? Right? So anyone has any questions about it? No questions? Right. So this is not an emergency thing, but I just put it in because I know it's a very common thing in primary care. So it is compression fractures, mainly the wedge fractures, osteoporotic fractures, elderly people. You see often in your clinic, 100% and fully confident with that. So the symptoms, sudden onset of back pain, pain worsening was lying flat because the axial load and compression of the vertebral body. So here you need to identify between the compression fracture and the metastatic spinal cord compression. So with the metastatic spinal cord compression, it is a severe pain with neurological deficit. Right, so here in a way you can differentiate. With the compression fracture, it will be more localized pain without neurology. Okay. The heart loss, kyphosis, the classic sign that could indicate osteoporotic fractures. Physical examination, tenderness, limited mobility, specifically with extension, because when you move to extension, you put more axial load on the vertebral bodies, and posture change. So the key points: pain was lying flat, limited extension. These are the very 2 signs that would indicate straight away compression fracture. So management, the classic management, you can get X-ray just to know how bad is it. Can you request that in primary care?
Yes. So it's stipulating it has to be for that reason.
Okay. So it's why you requesting it? Okay. Yeah. Right. Second thing, you need to do the bone profile. That's your job, guys. You know better than me. Myeloma screen, pain optimization, bone health management. Refer to osteoporotic cranial DEXA scan. That's more, you know more about that. It is according to your criteria and pathways, but usually you don't need spinal input. If it is pain is controlled, you can control the pain, manage the bone health just to avoid reoccurrence. There's no neurology, it's just pain, so just manage it through primary care. When would you consider emergency input? If it is acute, that's number one. Number two is patient unable to mobilize due to pain. So they can't walk. They just came to your clinic, they lied, I can't walk. There is a significant pain. Okay. Number three is there is acute neurological deficit, because that would indicate that there is a compression and the vertebrae start to collapse. Okay. So I mean acute neurological, you might thought there's a weakness in the leg because of the pain, but here we're talking about significant neurological. So try to assess the muscle power from different positions, from standing, from sitting, and there is imbalance. You will see a hyperreflexia. You will see significant neurological here. Okay, that's very unlikely, but this is the cases that we consider surgical intervention, and it is mainly vertebroplasty. It is not a preferable procedure because there's a high risk of infection, and you might need to do more multiple level later on. And usually with a patient with compression fracture, there's a lot of comorbidities, elderly people, so the risk profile of the surgery is quite high. So it is something to try to avoid as much as you can. But however, these are the things that only we consider surgery: acute, significant pain, patient unable to mobilize, associated with neurology. Is that clear? So in general, yeah, any questions regarding anything for the spine or accessing the emergency services?
No, thank you very much for your time. It's really interesting, and those case studies bring it to life, what we see in primary care.
Yeah.
Give it lots of references. So we will be sending out the slides. Denise at the Training Hub will be working away and getting the recording online, and we'll share it in the NATH website resources so that you can watch back.
All right.
So how do you diagnose an unstable compression fracture?
So basically, unstable compression fracture that will cause compression of the nerves, depends on the level. If it is in the thoracic area, that will cause spinal cord compression. Okay, so in that case, you expect significant neurology. Okay, so if it is the spinal cord compression, it will be very similar to the metastatic spinal cord compression symptoms. So severe pain, reduced sensation like a band time around the torso. You will get hyperreflexia in the lower limb, gait disturbance. So the key is the neurology. If it is unstable compression fracture, if that is in the thoracic area. If it is in the lumbar area, you would expect some sort of Cauda Equina symptoms, because it will be compressing. If it is collapsed and compressing the Cauda Equina descending leg root. So neurology is the key. Did that answer your question?
Any other questions, please turn off your mics or write in the chat. Sorry, I don't know if you put this earlier. Do you have an lower age limit to your service? Appreciate it's probably a low demand, but
so for emergency services, mainly it is for adult, mainly for 18. We have for that's for the new spinal assessment unit. For pediatrics, like any sort of fracture, fall, anything like this, it's more ED, referred to the ED, will be more the spinal fellows.
yeah, I think it was very informative.
Okay,
Thank you again for your time. And just we've got one more question. Sorry. How often can have compression fracture without neurological deficit?
So that's happened. Actually, I've seen just patients. So it's mainly it is the burst fracture. It will be more the vertebrae start to. It's unlike with compression. It will be more with burst fracture. It will be more pain. Okay, you will get neurological symptoms and radicular pain, but without deficit. So when you see someone with compression fracture without neurological deficit, you just x-ray them, act, as I said, normal management, get blood test for bone health, myeloma screen, pain optimization, that's usually what you do, and this is very common. Yeah, so it's a compression fracture, the wedge fracture without neurological deficits all the time. But what I meant that you have a compression fracture is unstable, doing neurological compression, but without neurological symptoms. That can happen. It's not often, but that's the reason we need to X-ray them all the time to see how bad is it before doing any second step. If that makes sense.
All in the objective testing.
All right.
So just so you know, I will start to round it up there. As I said, you will get the recording as well and slides so you can look back should you get these patients again. Just so you're aware, at NATH, we do lots of other education sessions. So if you go on the NATH website, or we've got the Grow Not app, that's where you can look for any of these further courses to help you in clinic. But thank you for your time. Have a great afternoon all.
Well, thank you for
and
the
thank you,
invitation,
Ahmed.
guys.
Really appreciate your time.
No, it's absolutely fine. Thank you, guys. Nice. Bye.